kick off our OBGY Viva on female infertility. Begin whenever you're ready.
I'm ready.
To start, explain the significance of the HSG hysterosalpingography test in diagnosing female infertility.
So HSG is generally considered as an initial test for tubal patency, and it is a contrast X-ray done on the 8th or the 9th day of this menstrual cycle, where a radio-opaque dye injected into the cervix and an X-ray is clicked, and we see whether the dye enters the uterus and the tubes, and we check out for the spill of the tubes in the peritoneal cavity, which indicates that the tubes are patent. And it will tell us whether the tubes are blocked or patent, and the site of block can be determined.
Impressive explanation. Now moving on to theoretical knowledge. Can you differentiate between primary and secondary amenorrhea and discuss how each might relate to female infertility?
Okay, so the primary amenorrhea means that the patient has never got her periods till now, and secondary amenorrhea means she has got her periods and now she has stopped menstruating. So primary amenorrhea patients, we need to investigate further. There are different causes of primary amenorrhea in order of frequency. The Turner syndrome, the RMKH, androgen insensitivity are the causes. And secondary amenorrhea, the most common causes is pregnancy, and then PCOS and anovulatory disorders are the causes of secondary amenorrhea.
Now, let's shift to a clinical scenario. You receive a patient with irregular menstrual cycles, hirsutism, and elevated testosterone levels. What could be the potential diagnosis, and what steps would you take for further evaluation and management?
So this case which you have given to me is a typical case suggestive of polycystic ovarian syndrome because of the elevated testosterone levels, what you have told me, and because of irregular periods. So there's an ovulation, and Rotterdam criteria are the ones which are used to make the diagnosis of PCOS, and an ovulation is the main reason why the patient of PCOS is infertile. So I would like to evaluate the male partner. If the male partner everything is okay, and I would like to go for ovulation induction in the female for achieving fertility. And letrozole is currently considered the first drug of choice for ovulation induction. We also need to remember about the lifestyle modification. Weight loss is extremely important, and also metformin or myoinositol can be added as insulin sensitizer to help the patient in achieving the weight loss and improving the ovulation rates.
Excellent analysis. Can you explain how endometriosis might impact fertility and the diagnostic steps you would consider?
So in endometriosis, there is presence of endometrial gland at places outside the uterus. So there's formation, there could be adhesions in the pelvis, there is formation of a chocolate cyst, and there's multifold reason why a patient of endometriosis is infertile. The primary really being the anatomical distortion which happens because of the adhesions. The tube and the ovary are pulled in different directions. So there is anatomical distortion. Second, a big chocolate cyst may prevent the ovulation from taking place. Plus, a lot of pro-inflammatory mediators are there in the pelvis, which can also lead to sperm phagocytosis and impair the sperm capacity to fertilize the egg. So it's a multifactorial reason why the patient of endometriosis is infertile. And for evaluation, laparoscopy is considered the gold standard or investigation of choice for endometriosis, whereby I can see endometriosis and also simultaneously treat endometriosis.
Spot on explanation. Now, let's shift gears to a clinical case. You have a patient presenting with primary infertility, regular menstrual cycles, and a partner with normal semen analysis. How would you approach the evaluation and management in this case?
Okay, so overall, as you said, that the male partner is normal and the cycles are also regular, so that generally rules out the ovulatory dysfunction. I would start the female on folic acid supplementation, because it's always good to keep her on folic acid supplementation because it's preconceptional folic acid is required. And I would like to evaluate her by doing the tubal patency test, the HSG, and then also do a basic sonography to see how the uterus is, and then I would tell them the importance of the ovulatory period and planned relations.
Great comprehensive approach. Now that wraps up our OBGY Viva. Well done. If you have any questions or want to continue, feel free to let me know.
Can you grade me out of 10?
Absolutely. I give you a solid 9 out of 10. You demonstrated excellent knowledge and a well-rounded approach to the scenarios. If there's anything specific you'd like to discuss or improve, let me know.
So as you could see, student, this is how a typical Viva would go. Initially, we begin the discussion on what is HSG, and the examiner just asked me something directly which is not connected, but amenorrhea definition, primary, secondary, and then we went on to PCOS discussion and how would you evaluate and give a complete rounded answer. I said that I would like to evaluate the male partner also. It's very important in the exam. Also told about the lifestyle modification. These are really nice way to give answers in the exam, well-rounded of answers. And then there was a clinical case shown to me, and then we went on to discuss some points about endometriosis. So this is how a typical Viva would be going, and hope you enjoyed this session.